Hello, I'm going to talk about the antipsychotic drugs, especially focusing on their receptor action. I'll begin this discussion with focusing on the concept of the potency of antipsychotic drugs. Potency, by definition, is related to their affinity for the receptor, as is the case in all other pharmacological agents. And here, when we talk about the potency of antipsychotics, regardless of first or second generation, we mean the affinity for dopamine D2 receptor. We will mention later on that the second generation antipsychotics' major difference with the first generation antipsychotics is the fact that they are not considered much active on blockade of the dopamine D2 receptor. On the other side, they are active more strongly on the blockade of serotonin 5-HT2A receptor. However, whenever we talk about concept of potency without specification of the receptor, even if we are talking about second generation antipsychotics, we are still dealing with the concept of dopamine receptor blockade. This is of paramount significance because everything related to extrapyramidal side effects in one aspect of it at least is related to the dopamine blockade. So, what antipsychotics are considered high potency? If you are asked this question in general, remember all first generation antipsychotics are considered high potency antipsychotics, plus two of the second generation antipsychotics with strong D2 blockade activity. These are in general the high potency antipsychotics. Those two second generation antipsychotics are ziprasidone and risperidone, and the way to memorize them is their name ends in idone, which is in some ways, in my opinion, similar to inhibitor of dopamine, idone, inhibitor of dopamine, if you have some flexibility. So consider only these two among the second generation antipsychotics as being potent dopamine blockers, and because of that also consider the high possibility of extrapyramidal Parkinsonian side effects. Among the first generation antipsychotics, yes, we mentioned that all first generation antipsychotics are indeed high potency. However, if you're asked which one of the first generation antipsychotics have the highest potency, the answer is haloperidol. That's the highest potency first generation antipsychotic drug. And then if you are asked which one of the other first generation antipsychotics have higher potency than other first generation antipsychotics, other than haloperidol, or if you are given a multiple choice question and you're asked which one of the first generations have the highest potency and you don't see haloperidol in the choices provided, remember among phenothiazine antipsychotics, fluphenazine is the one with highest potency, not even chlorpromazine or thioridazine, but fluphenazine is the one among the phenothiazine that's considered real high potency phenothiazine. And then we have pimozide and thiothixin, which is a thiazantin. These are the highest potency first generation antipsychotics. Again, haloperidol is always on top of the list. Before I go ahead with the low potency antipsychotics, I need to talk a little bit about why I have categorized this whole story the way I have done it. It's to be able, or to enable us to have a possible prediction of the extrapyramidal side effect that could occur with any one of these. For understanding of this, we need to know extrapyramidal side effects, Parkinsonian side effects. As the name indicates, is secondary to a pathophysiologic process in which there is an imbalance between dopaminergic and cholinergic neurotransmission in a way that dopaminergic is gone down and cholinergic is raised. Because of that, either destruction of the nigrostriatal pathway or that mesocortical dopaminergic pathway, or blockade of dopaminergic pathway pharmacologically will result in Parkinsonian side effects of bradykinesia, rigidity, tremor. This also informs us about the fact that any condition that increases the muscarinic level or decreases dopaminergic level works in favor of extrapyramidal side effects and it produces and worsens this side effect. And any drug that is not high potency, in other words, it's not a potent blocker of dopamine D2 receptor, or any drug, and here is the kick, or any drug that has an intrinsic muscarinic blockade activity, especially strong muscarinic blockade activity, will be devoid of that extrapyramidal side effects. And this is how I've categorized the other receptor discussion as well as the low potency drugs. So before I reveal the low potency drugs categorization based on this side effect or clinical point, I want to go ahead and talk about the other receptor activities other than D2 blockade, excuse me. So as you can see here, I've categorized the receptor activity of the antipsychotics based on their D2 blocking activity, their muscarinic blocking activity, and their other receptor function. Now I want to talk about muscarinic blocking activity. When it comes to talking about muscarinic blocking activity, we need to first figure out which one of these drugs have no muscarinic blocking activity, which means which one of these drugs have the highest potency, highest possibility for extrapyramidal side effects, regardless of their dopamine activity. Why is it so? Because, as we mentioned, almost all of these drugs, except one that I will mention at the end, are capable of blocking dopamine receptor and therefore are capable of causing some degree of Parkinsonian side effects. However, if the drug is not able to block the muscarinic receptor at all, that means regardless of the degree of dopamine blockade, that drug is capable of producing extrapyramidal side effects. What are those drugs? Among the first generation antipsychotics, haloperidol does not have any muscarinic blockade activity, and among the second generation antipsychotics, aripiprazole and ziprasidone have no muscarinic blocking activity. How to remember this? You can remember halos, because the ones with the Z in their name, including aripiprazole and ziprasidone, and don't add clozapine because I said that's just an exceptional case that we will talk about at the end. Haloperidol, aripiprazole, and ziprasidone, or halos, are the drugs with no muscarinic blockade activity. Remember, if you see halos, it means you are possibly suffering from Parkinsonian side effects. Which brings us to the next topic, and that's which one of the antipsychotics have strongest muscarinic blocker activity, or atropine-like action. Remember, among the first generation, thioridazine have the most potent muscarinic blocking activity, and despite the fact that thioridazine is a first generation, and we consider all first generations in the facilitated approach, in the general approach, potent antipsychotics, thioridazine have the least possibility among the first generation antipsychotics to cause extrapyramidal side effects. That's thanks to its very high potency in blocking muscarinic receptor. Among the second generation antipsychotics, clozapine is the one with strongest atropine-like or muscarine blockade activity. So now a big picture is gradually forming in terms of interpreting the extrapyramidal side effect possibility in terms of interaction between the potency of blockade of D2 receptor or blockade of muscarinic receptor. And this brings me or us to the last topic in this regard that I wanted to talk about, and that was the low potency antipsychotics. You may think of, okay, we have talked about the high potency antipsychotics, therefore all the other ones are low potency. But here I want to talk about the low potency antipsychotics in terms of this extrapyramidal side effect, and in other words, I want to say which one of them are safest in terms of no extrapyramidal side effects. Which one you think should be that one? Low potency ones are the ones with minimal or no dopamine D2 blockade activity, yes? Remember that the ones with minimum remember those with minimum D2 blockade activity can still cause some degree of extrapyramidal side effects if they have no atropine-like effect, okay? So we want to know which one are the best clinically, which means which ones have some muscarinic blockade activity and have some minimal D2 blockade activity. Remember, olanzapine and quetiapine are the ones with minimal D2 blockade activity, which means some degree of D2 blockade activity plus some muscarinic blockade activity. Therefore, they are almost devoid of any Parkinsonian side effects. And then finally, clozapine, the last resort in antipsychotics treatment because of its frightening, catastrophic side effect possibility of agranulocytosis. This drug, this wonder drug, is not used ever as the first choice. Clozapine has absolute no D2 blockade activity, and if you remember our discussion of muscarinic blockade, it is indeed a very potent blocker of the muscarinic receptor. Therefore, clozapine is absolutely devoid of extrapyramidal side effect. Dopamine D4 receptor is blocked instead of D2 receptor by clozapine, and that's another point to remember about clozapine. Then we have this minimal, maybe less significant point about aripiprazole. Aripiprazole also has minimal D2 blockade activity, but we should consider it a drug that's partial agonist and mixed agonist antagonist. If you remember, we mentioned aripiprazole and ziprasidone together with haloperidol as drugs with no muscarinic blockade activity. Okay, so we still expect some degree of extrapyramidal side effect just because of its minimal D2 blockade activity. On the other side, remember, it's a partial agonist at D2 receptor, and it's also considered mixed agonist antagonist. Which means what? It means, well, similar to all other second generation antipsychotics, it should have some blockade of 5-HT2A. However, it is agonist at 5-HT1. That's why we call aripiprazole a mixed agonist antagonist. And again, it has no muscarinic blockade activity, some degree of dopaminergic blockade. Okay, so are you ready for the big picture finally? The big picture regarding the extrapyramidal side effects would look like something like this. So, the high potency antipsychotics, among the second generation, the ones with idone on them, such as ziprasidone and risperidone, plus all first generation antipsychotics, especially the four drugs that we mentioned: flufenazine of the phenothiazines plus haloperidol, thiaxanthin, thiathixin, and pimozide. These are the high potency antipsychotics, therefore they have high risk of extrapyramidal Parkinsonian side effects. Then we have the other category, which are the drugs with no muscarinic blockade activity, considering the fact that all antipsychotics block D2 receptor to some extent, and they included haloperidol among the first generation, and then aripiprazole and ziprasidone. These are again the drugs with high risk of extrapyramidal side effects, especially haloperidol. Okay, as you can see, the one that's shared between two categories is haloperidol. It is not only a high potency drug, but it's a drug with no muscarinic blockade activity. Then we have the drugs with least extrapyramidal side effects. These are definitely low potency, but among the low potency one, we have the clozapine, which is actually a very potent serotonergic blocker drug and D4 dopaminergic blocker, but because it lacks D2 blockade activity, it doesn't cause extrapyramidal side effects. And on the other side, we have drugs with strong muscarinic blockade activity, and again, clozapine is in this category as well. Therefore, the drug with least extrapyramidal side effect is clozapine. Among them, also thioridazine of the first generation antipsychotic of phenothiazine group are the ones with the strongest muscarinic blockade activity and least extrapyramidal side effect, despite the fact that thioridazine is a general high potency or first generation antipsychotic. And then we have the last case of second generation antipsychotics, which have some degree of D2 blockade, but they have also some degree of muscarinic blockade, and therefore they have minimum risk, not the lowest risk, but minimum risk of extrapyramidal side effect. They include olanzapine and quetiapine. The way to memorize these four drugs, thioridazine, clozapine, olanzapine, and quetiapine, is cocktail, C-O-Q-T. If you give a patient a cocktail, you will prevent cogwheel rigidity, which is the hallmark of Parkinsonian symptoms. Okay, that's how you remember that. cocktail, or COQT, for clozapine, olanzapine, quetiapine, and thioridazine. This cocktail prevents coccygeal rigidity. And if you have some space left in your hippocampus to memorize, aripiprazole is a partial agonist and mixed agonist antagonist for the serotonergic receptor 5-HT2A, 5-HT1. That will be also some point to remember. But after this most important point is being taken care of, let's focus on this minimum subject here, the other receptor action of antipsychotics. When you are asked about the autonomic action, just remember, as a general rule, phenothiazine antipsychotics are the ones with highest autonomic side effects. Okay, so phenothiazine antipsychotics are not only the ones with some degree of muscarinic blockade activity, especially thioridazine, but not haloperidol, but all are the ones with the strongest alpha-1 blockade activity. Which brings us to the next question: what's the basis of impotence with antipsychotics? There are two bases for that, not just blockade of dopamine receptor and dopamine being prolactin inhibitory factor, and the result being the increased levels of prolactin that decreases libido in males and can cause also gynecomastia. But there is a second arm to this impotence, and that is inhibition of ejaculation due to alpha-1 blockade. And again, remember, all antipsychotics, even haloperidol, has some degree of alpha-1 blockade activity. But remember, among the antipsychotics, especially two groups, phenothiazines, and among phenothiazines, again, if your hippocampus let you remember this, chlorpromazine has the strongest autonomic side effect and alpha-1 blockade activity. And among the second generations, clozapine is the one with the strongest alpha-1 blockade. However, remember, despite the fact that haloperidol looks like it has absolutely no receptor blockade action than blocking dopamine D2 receptor, the only other receptor that's blocked by haloperidol is also alpha-1. So if you are asked true or false, the patient who has received haloperidol is prone to orthostatic hypotension at the initial doses, that is actually a true statement. H1 blockade, again, remember, all antipsychotics are capable of blockade of histamine H1 receptor. This has one exception, and that's again important exception of haloperidol that we mentioned. It only blocks dopamine D2 and alpha-1 receptors and nothing else. Another point related to dopamine, to histamine blockade and to some degree muscarinic blockade is their relationship with sedation. So the ones with strong muscarinic blockade activity, which was our cocktail as we mentioned, plus all antipsychotics except haloperidol, which are histamine blockers, are capable of sedation. If you are to choose between them, always choose the ones with H1 blockade activity, which means all antipsychotics. So you need possibly to focus a little bit more on the cholinergic blockers. And then the serotonin action. Remember, all second generation antipsychotics are serotonin inhibitors, 5-HT2A blockers. I haven't been able to figure out if molindone belongs to first or second generation. Otherwise, remember, if molindone sounds like a second generation or a new drug, remember it's the only second generation antipsychotic that has no 5-HT2 blockade activity. And then remember it by challenging yourself through this true and false statement. True or false, only second generation antipsychotics have anti-serotonergic or 5-HT2 blockade activity. That's false. Even first generation antipsychotics, which are notorious for their D2 blockade potency, have some degree of serotonergic 5-HT2 blockade activity, and it's not specific to just second generation antipsychotics. And then that is what we wanted to cover here. Hope this helped with the receptor activity of the antipsychotics, and I believe that's the most clinically significant aspect of antipsychotics to bear in mind. Again, remember, known drugs of the second generation are the high potency in terms of their D2 blockade activity. Thank you very much and have a wonderful studying. This was another example of output-based learning. It's by no chance or by no means an attempt to provide a comprehensive medical discussion. It was for the sake of personal learning and sharing the process of personal learning with other fellow doctors and clinicians. Thank you very much and have a great day.